let me talk a bit about where we're going to go. And I tried to give you the bottom line in the handout that I have, and I hope everyone has the handouts. There are 2 or 3 more down here if you missed them. The final punchline. So I'd like to talk about these aspects of it. But before I do that, get into a little bit about what the market looks like, because this is really about insurance reform. Fundamentally, at this point, although I think what we're going to find is that the other parts of the reform law maybe are as important or perhaps even more important as this rolls out. So we're going to get into some of those issues as well. The healthcare reform bill, and some of you I know from other audiences have seen some of these, so I'm going to flip through them fairly fast, was basically about 2 things. Covering more people and getting those nasty insurance companies to stop doing the bad things that they do. And I have to say, as some of you know, I was CEO of a health insurance company for a while. It was very discouraging to have little kids make fun of you and people say bad words about you. No one loves their insurance company for good reason, because there's some issues. And so Mark's going to get into some of those things. So can we get them to do bad things, stop doing bad things and cover more people? The easy one was the kids who move back into the basement. And so if they're living in your basement anyway, why not put them under your family insurance policy? So putting kids on up to age 27, no brainer, easy. Medicaid expansion, obviously a lot more difficult, and we can talk about that because there are major political issues with that, as well as perhaps some financial questions in terms of what happens with Medicaid expansion, but it's clearly an important part of what's going on. And then we get to things like the individual mandate, which is where the rubber hits the road in multiple ways. Now, this came out of some intense negotiations, otherwise known as deals. And some of you have seen this, but this is very important because I have an historical picture of the negotiating session where this was put to bed. It's very interesting to see because this is what it looked like. Now, you may think that I'm joking, but actually, when you look at this picture, you can actually identify all the players. The AARP is over here. You know it's AARP because they're little droopy, sort of sleepy looking, you know, they need their naps in the afternoon. Oh, listen, I resemble that. I don't have any trouble with that at all. All they wanted was to give them the drugs. Just get rid of the donut hole. They got it. They got it. They got the donut hole taken care of. We can talk it. Now, Big Pharma over here, you know it's Big Pharma because they got 2 forms of medication. Had to be Big Pharma. All they wanted was stay away from drug pricing and don't let those people import drugs from Canada. That screws up our whole market. They got that, okay? But in order to do the drugs for the old people, you had to get the drug companies to cooperate, and that's where the money came from to do the switch. So it was a part of a deal, and it worked. It stuck pretty much. Now the docs are sitting here. You know it's the docs because they got the cards really close to the vest, right? Had to be the docs. All they wanted was to stop messing around with that sustainable growth rate formula for those who are wonks out there, the sword of Damocles that says I'm going to cut your rates in Medicare each year by 27%, and then I don't do it. So it's sort of, you know, it's not really nice to do that to people, to threaten to cut off their legs and then say, oops, just kidding. That's what Congress has done every year. They want to get rid of that. They didn't get it. That's a biggie. The hospitals are sitting over here. They're pretty happy. They're leaning back. They got their cards. They're happy because all they wanted to do was get their uncompensated care taken care of. Just stop giving me people that don't have money. And if you get them insurance, that takes care of that. They got what they wanted. So they're pretty happy about it. The employers, they're off to the other side. Would that be right or left? I don't know, depends on how you look at it. They were sort of out of it, except that that's important because they were in the game the last time around and were really negative. So except for the small business coalitions, the Federation of Independent Business, the Business Roundtable, the big businesses, they were pretty much at least tacitly supportive, if not positive on this. They certainly weren't negative. The insurance industry, now again, you know it's insurance. This is dead ringer. Because they got those cards hidden down, they got the ace down there. Had to be the insurance company. They just wanted, they said, look, we'll stop doing bad things if you bring us more customers. It's simple. Just give us a bigger pool and it all works out. So they were happy with this, unlike the last time around when they were adamantly against it. So the insurance companies, they were pretty happy with the whole thing. And of course, Obama is sitting here. He had most of the cards the first time around. Doesn't anymore. So we have some issues with that. Now, the point I want to make is this was a set of deals that were politically very much intertwined with each other and were essential to make this thing work. That's really interesting because I'm not a political scientist, but the fact that we managed to pull that off without major disruption. What you've seen since then is basically working around the edges, trying to get the regulations written in your favor. So, and by the way, the insurance companies are still the whipping boy, so we still make nasty comments about them because that's the way politics is played. But by and large, they were very supportive, and they still are very supportive in this whole thing. So now you know everything you need to know about healthcare reform. Okay, that's it, all in one picture. I was tempted to end this set of slides right here, and then I thought, nah, probably better spend a little more time talking about it. Because the one really key one that never got discussed was the subsidies. These are the two subsidy levels, and they never got described this way, but I went back and did the arithmetic and put it in dollar terms rather than percentage terms. If you look at a $1,000 a month policy, ballpark, reasonable number, if you're in the slightly above the Medicaid poverty level, Medicare qualification level, you'd get about 95% of that paid for by the subsidies. This is really important. Even in middle income at about $50,000 a year, you'd have about half your premium paid for if you were in the exchanges. Exchanges and the subsidies are critical to making this work. And I want to talk about that later, I think, because that's going to be an important touchstone for what the Republican counter to this might be and what it really was. So we'll talk about that a little later. They operate through the exchanges, and the exchanges I've found really puzzling because it's not a big deal. It's just a big website with all this stuff on it to look at. So the exchanges are there, and we need to consider whether they're in fact going to make it or not. And then we have the small employer subsidy, and this is an interesting point because it's a major difference between the Republicans and the Democrats. The small employer subsidy is basically the essence of John McCain's proposal, yet it was never really embraced. And as it came out, it was fairly limited. So the tax subsidy for small employers is just for small employers. It's pretty generous, actually. But it wasn't enough to get the small business people on board. So they've still pretty much been negative with that. And the numbers are pretty big. By the time you look at it, it's about on a $10,000 policy, it could be, say, $3,000 a year. Could be a pretty significant number. So now, where is this thing going to go? Well, now we've got the election. And so the election is a big one. Now, I won't try to prognosticate about that because I don't know any more than you do about where it's going to go. But again, it may cause troubles because the Democrats just can't explain this. And if they could only explain this a little bit better, maybe some more people would catch on and be positive, but they can't seem to do that. I didn't get a laugh out of that. I think that's hilarious. I thought that was really funny. So the elections are critical, but I don't think they'll derail them. The big question is, what are they going to do? At the end of my street, I live in Rocky River, there is an interesting place that has a sign on it that says, "The sweetness of doing nothing limited." I thought, this is so cool. What kind of business has a name like that? Well, it turns out it's a consulting firm that helps Congress to figure with their agenda. Nothing's going to happen. There's still going to be stalemate. They probably won't get around to doing anything. Actually, for those of you who are retired, they make T-shirts that say that on it. They sell to retirement homes and such. I got to get a load of those. I just love to have it. The exchanges are really important. I want to seriously deal with that just a little bit. The exchanges are important, and the various other elements that are in there, I think, are important beyond the exchanges. We'll talk about the exchanges, too. And this is where the part that most people don't even know exists, but I think maybe will the ultimate change and probably will tie back to some of the other discussion items we'll have this morning. Accountable care organizations are really big. They're going to grow like mad, and they're a method for people to continue to do care, particularly for the elderly, for people who qualify for Medicare, but it will also be for businesses as well. Around here, University Hospital is the big one that's actually out of the gate. There'll be others. you continue to bill for Medicare, but if regular rates, but if you hit quality standards that are specified for the enrolled population, and if you drive the cost below the actuarial forecast, you get a bonus. You get a significant bonus, 50% or so of the difference back. This is a huge incentive for people to go play nice in the sandbox, figure out how to reorganize the system, and probably will be one of the biggest social science experiments we've ever had to figure out what works in reorganizing the system. So stay tuned. That will be very interesting. That will happen fairly fast. In the next 3 or 4 years, we're going to see some results out of these because they're out of the box now. The second one, PCORI, badly named, is the Comparative Effectiveness Group. They've got about $10 billion to compare different treatment patterns. And those are going to be interesting. They're going to inform physician practices, but I think they'll also be a part of designing new insurance models, maybe even malpractice suits. There are going to be some interesting data that will come out of those. That'll take a while because it has to go through peer review, literature. The whole idea is to make it scientifically valid. You'd think we did this already, but we really don't. FDA does not do this. The third is called the Innovation Center, and that is basically the process R&D, the D part for the feds to figure out how to do Medicare better. This could happen fairly fast because if something works, major changes in telemedicine, organizational structures to pay advanced practice nurses at a different level and different organizations, anything that somebody proposes that in fact works can be rolled out across Medicare immediately. So it's a very quick change item. And then the last one is your nightmare. It's the Independent Payment Advisory Board, IPAB, which is, if none of the above works, these are the guys that come in and start enforcing lower rates. This is the unelected bureaucrat part of healthcare reform. I always thought I'd like to grow up and be an unelected bureaucrat someday. So these are or the death panel, if you'd like, or put any other thing else on it. These are the bad guys who are going to come in and tell us how to lower cost, and Congress has to take it. They have 90 days to come up with an equivalent amount, or it becomes law. This is the part that people are worried about. I think, and I'm not going to dwell on this because I want to make sure we get to the other things. I use this framework in my health policy and management class to try to think about what happens, and particularly what the government thinks it's doing, what it's after, what it thinks it's doing, what kind of tools it uses, what kind of assumptions it makes about the real world, and that's sort of straight policy analysis, and then what signals they're actually telling people. Expand, contract, take risks, don't take risks, things of that sort. And as a result of unintended consequences, then what does the government do? Change the policy, expand, contract, broaden or tighten a variety of things. This is a framework that I use to think about unintended consequences, because the healthcare reform bill will absolutely have unintended consequences, like anything the government does. So the real question in seeing what's coming next is, so what's the reaction to healthcare reform, both in the real world, where people live and make decisions, and in the policy world? And that's going to be the tricky part. It's a little early to tell, but we'll find some interesting ideas there. Exchanges, I can do the others fairly fast. Exchanges will be a big success, I will propose. And we'll come back and talk about that. The big issue I had with the exchanges is anybody going to show up? Well, the regulations that have actually been written are really good in terms of lowering the level of risk and letting people get in. There will be a lot of competition. There will be every insurance company will want to be in this game because they're going to make it much lower risk than I assumed, and reasonably lucrative, I think, for the insurance companies. And we've already done this. Medicare Part D is a plan very much like what we've got here. There's going to be good pooling, and then they have these risk reduction things. The big thing, and I'm trying to lead into Mark on this one, is the exchanges and the reform on insurance will change the overhead cost. And I think that'll be important to changing the effectiveness of the insurance business. And so I think we're going to have a lot of people on the seller side, insurance companies. We're also going to have a lot of people on the buyer side. So I would predict the insurance and exchanges will be a success. And if you looked at the Wall Street Journal yesterday, even if they don't make it in the federal level, There will be private exchanges. The front page of the Wall Street Journal has an article about private business doing this. It will definitely be there. The subsidies are going to be a big one. Both it's too big and costing us too much money, but also it's too little. We need to do more. Those are going to be interesting questions. If you go back to the chart that I handed out, that subsidy never really got discussed very well, and I think is a legitimate thing. The Republicans, if they got in power, will want to do more here. So I would argue that that will be part of the replace, if they ever got to the replace part of the repeal. And the Republicans will want to expand that because taxes are the way that Republicans like to spread the wealth as opposed to direct subsidies. We will continue to see Obamacare. This is the unpopular part for those who are retired. Because even if it doesn't work, even if it gets repealed, it's going to come back in a variety of ways. The reason why we'll see it is this. Obamacare is not for the elderly. Paul Ryan wants to do this for the elderly. He basically wants the same thing. So it's interesting. And if you look at the numbers, they're pretty compelling. The average Medicare person puts about $65,000 into the bank compounded. So the contributions add up to about 65. But when you look at the typical person, they take out of the bank about 174. That is unsustainable. That can't be. You can't run an insurance company like that, particularly when the number of retirees are going to double and the number of dependents are going to go from four dependents are going to go up to 4 dependents for every 10 workers from about 2. This is fundamentally going to change the nature of it. So we got to come up with a new course of financing. And the place we have to look, it's like Willie Sutton. They asked him why he robbed banks, and he said, that's where the money is. So where are we going to go to get this? Well, the elderly have 2.7 times the net worth, about double the net worth of the rest of us, mainly because of Medicare, because we changed the way that people get old and go into their retirement years. That's going to be part of it right there, why we have to address this. So we're going to do this, and Paul Ryan will lead the way. Even if he's not elected, he'll still be leading the way. He wants to have it, exchanges, all the things you read in the Ryan plan, as much as we know, look like Obamacare. I think this is total irony that we're having him on the other side here. This is actually a picture of a little-known picture. It's the same place as that other one, but I just love polar bears. They're just so cool. Anyway, so Ryan, I think he's asking the right question. He just may not ever have the right answer. So where are we going to go? Medicare is clearly going to go broke, no question about that. The wealth is in the 65 population, so it'll have to be figured, some way to tap into that. A voucher plan really will reduce demand. They're right about that. But the trouble is it can't be just a flat voucher because then politically it's not going to work and we'll have lots of issues that will be here. The exchanges really do work. We know market mechanisms work. We already have that in the Medicare subsidy plans, the Medigap policies. We have it in the Medicare drug plans. It's not a big extension to see how this might work otherwise. So we can definitely do that. But the key is, I think, on the supply side. So we've spent all this time on the demand side. The supply side is really important. So how do we pay people for things? That's the universal question. And we really haven't done that except for value-based purchasing, which is the key word, VBP, that is in the law, has been the law the last several years, and will continue to be, which means if you screw up in terms of quality, you're going to get paid less. If you do well, you're going to get paid more. That's a really big market base. So the bottom line for all this is, how does it pay off in all these other things? Evidence-based care, purchasing, value-based insurance, how we deal with drugs, how we deal with patient experience and quality. I think those are really important issues to deal with. We've come a really long way, but it's not clear where we're going to wind up. This is actually another one of these real finds. I actually got this picture the other day of evolution, and it actually is true that we've evolved from that to this. And so the real question is that where we're going to wind up, or is this the next step in evolution that maybe will be where we'll wind up? I don't know.